Okay, I think we're all back. So in this talk, I endeavor to answer the question with all that we have in terms of diagnostic information now with diagnostic tests, is the physical exam in fact obsolete? Okay, so that's our question. And let's see where that goes. I have no conflicts of interest here, except to say that I do have conflicts, but they have nothing to do with the physical exam. Okay. So let's first answer the question. I utilize some aspect of the physical exam in my work with patients. And that could be if you're even triaging patients, you know, with vital signs, but okay. So for the majority of people here, or everyone has answered yes. Okay. And so we all know the scenario. The patient presents to the office saying, I want a complete physical with all the lab tests and everything. And this is the point where you respond, should we supersize it? Right? Do you want that supersized? You know? So, yeah. So what does this mean? So now I'm going to ask you a question. When I go to the doctor for an annual checkup, I receive a physical examination. Yes or no? And everyone says yes, but if I asked you, was it a complete physical examination? Right? Everyone would say no, right? I just went to my doctor for my physical, and I think I just counted the number of checks. So our checklist at UCONN for the physical exam checklist is 88 items. He checked 4 of them. Okay, 4. Okay. All right. So what questions we're going to ponder as we go through this talk? So what is a complete physical? And with respect to particular elements of the exam, why exactly do we do what we do? And are there parts of the exam that are more reliable than other parts of the exam? And the question really is, given the advancement of medicine, the increasing sophistication of medical diagnostic testing, and our increased reliance on laboratory testing, should we consider abandoning the exam altogether? And I think that's a very real question, given the acuity of a CT scan and given the diagnostic value of a rapid strep test, you know, and so on. So the reality is, I think we have to sit with this question. And so the overview of this talk is going to be, I'm going to give you a little bit on my research, which was on building a rubric to improve physical exam technique. And then we're going to go into a deep dive in the history of the exam. It's very interesting. The history of the physical exam in our country as it exists in our current healthcare system. And then I'm going to look at the data on accuracy and reliability of physical exam elements. And you're going to be surprised at the intra-observer variability and how unreliable some of the elements are. And then I'm going to go to the U.S. Preventative Task Force. I'm going to say, all right, if I said the physical exam's necessary, does the U.S. Preventative Task Force, which we all know is the most unbiased, it's not ACOG, it's not AAP, it's not AFP, it's the most unbiased organization, do they have anything that actually relies on the physical exam in their evidence-based database that sits in the category A or B recommendations? And you'll be surprised. So, and then some conclusions. So my expertise in this technique, I don't have to tell you, but I basically saw that at the medical school, we had a lot of heterogeneity in how we were teaching physical exam. There's a saying in medicine, we teach that which we most want to learn for ourselves. So I said, you know, I'm interested in really learning better technique on auscultation and percussion and so on. So why don't I, as part of being the director of this course, why don't we codify this? And what we did is we developed videos and it was myself, an internist, and a pediatrician. And we adjudicated all the evidence on Bates and all the other texts that were out there. And we said, okay, this is what we're going to agree is the correct Weber technique. And this is what we agree is going to be the correct Rinna technique, if you will. And this is going to be the correct way to percuss the sinuses. And we did videos. And then we said to the students, using these videos, we want you to use these videos, study them, to practice them on the patient instructors, and then we're going to test you. And we looked at students pre-video, post-video, and what we were hypothesizing is by using a standardized technique, as opposed to a patient instructor saying, no, you did that wrong, you need to do it this way. We use the video as sort of the standard. And we used then the patient instructors and taught through the preceptors, and we were trying to show that we could actually improve technique. And this is what our list looked like at the time. It was kind of cool. You either did it satisfactorily, unsatisfactory, or you didn't do it when you did a head-to-toe physical exam. This was a full physical exam. How long do you think this took to do on a patient instructor? It's like, yeah, 45 minutes, right? 40, it was an hour. It was, something like that, something crazy. And what was neat is the students could click on the thing and it would bring a nice video up, and it was nicely narrated. It was very cool. I'm very proud of it. And it's evolved. And actually this website is now in its like 5th iteration. And you can look at some of the materials if you actually wanted to check it yourself. But you'll see what we were trying to do is develop asynchronous education so the students could develop better and improve their technique, and then we would evaluate them. And what we found is that in evaluating students before the implementation and after the implementation and looking at the summative results, that we actually pulled up the mean. So students who were poor, I think it's better seen on this next slide, forget the numbers here, but the idea is we had a statistically significant difference in improvement on the number of items completed on a checklist and the process scores. And when we looked at the post implementation class, the number of students scoring below the mean was much lower. So we improved technique, and we were so proud of ourselves. And then of course I had one of my colleagues say, "Yeah, but have you made them better doctors?" I'm like, "Oh, damn, no, shoot, we didn't do that." But we taught them better how to do the physical. And then it started to occur to me, you've done this, okay, you've developed this thing, but how good is this stuff? And then we did a deep dive into actually what we were looking at, because all we did was we took the text and we said, this looks like a better way to do this in this adult population. This looks like a better way, but it really wasn't evidence-based. And so let's kind of do a little historical tour through the physical exam. And I think the thing that's most profound here is how recent it is, right? So we have Chinese medicine preceding Greek medicine, and you have Hippocrates hypothesizing. I don't know if he was the one who did it, but you had the evil humors, right? That was what circulated in the body. We didn't know about the lymphatic system or the circulatory system, but we had these evil humors, and it was the imbalance of these humors that would lead to health or disease. And then you had, sacrilege. You had Vesalius and Morgagni, literally dissecting cadavers, with Da Vinci, and now anatomy, real anatomy was being understood, and disease was being seen, and studied. But the art of percussion, which is the tapping, and there is a technique to the tapping, the idea that early on, this is one of the first things we had. They could outline liver, they could outline body part, percussion technique, and people actually perfected their skills in this area. So they thought they were actually accurately diagnosing human anatomy using this. And it was mere 200 years ago that auscultation began. And it began with, and I have a picture of it here, it began with Linnet putting his ear on the lens of a patient, and then realizing if he took and rolled it into a round thing and extended it to his ear, he could actually hear better. And this is sort of the primitive auscultation 200 years ago. And it was interesting how when tuberculosis was prevalent, phthisis, as it was called, TB is aerophagic, and hence it goes to the apices. And so they would listen for crepitants, listen for crackles in the apex of the lungs to make the diagnosis. There was no X-ray, right? But crackles at the apex with the right constitutional symptoms, and you had consumption. So if this is the beginning, percussing and auscultating, what about medical devices and the aids we use to aid us in physical diagnosis? Well, one of the fun things I did with my daughters, because as someone growing up in the sciences, I completely turned off English and history, and then my daughters are growing up and I'm like, oh my God, this is so interesting. I missed out on American history. So we studied American history and went all the way up the coast of the United States. And as I was going, I had an eye toward medical equipment. And so in Valley Forge, I saw this, the crude instruments used. And I go, my God, this looks like my shop, a hacksaw. There's nothing there that I would want to even go near today. And then in the Constitution, which is the oldest boat that sits in the Boston Harbor, they had the bottle of medicinals, and one of them was called squill water. And I thought, oh my God, what is in squill water? But this is, this is relatively recent. You're talking about remedies this was not folklore. This was modern medicine. Up until, so we call that sort of the traditional period, the modern period. We divide the physical exam up into these different times. And let's just say, in the traditional period, this is dating way back, history taking was good, but there was virtually no physical exam or clinical exam because all you could do was observe, and that was the days of Hippocrates and all the way coming up through the medieval times, and there's really no sense of differential diagnosis. We didn't even understand disease, Then you have the modern period where now with Laennec and Corvisart, you're developing techniques. You have history taking, and now because anatomical disease is being understood because people have been dissected, and there's been autopsies, if you will. There's now a better understanding of what disease looks like, and so great in diagnostics, terrible in therapeutics, right? And then we enter the postmodern period, which is what we are in now, where there's an abbreviated history, cursory physical exam, and painstaking attention to laboratory data and diagnostic imaging. We have enormous potential in terms of therapeutic benefit and an excellent differential diagnosis. But this is where we live now. And I guess I want to show you that when we look at some of the technologies that were used in physical exam technique, I want to point out three. The stethoscope, 200 years ago. The ophthalmoscope, 150 years ago. The sphygmomanometer for blood pressure, it's only 140 years old, And so you have things that are relatively recent when you think about the chronology of their development. So I take us back to Hopkins, really, where we say it's the birthplace of the modern medical education. And, and there'll be other institutions that claim it. Again, I have no tie to them, but I really believe it was Hopkins that started this whole thing with Osler. So I told you about Osler's essay of equanimitas. Osler was a Canadian by birth. He was a pathologist and then a physician. And then internists want to claim him as the greatest internist of all time. Family physicians, we say he was a family physician, but let's just call him a doctor. Okay. And he brought to bear, because of his skill in pathology and diagnosis and technique, he brought to his bear the idea that we need to revamp medical education, and we need to really focus on how we're going to train people differently, focusing on history, diagnosis, pathology, because he was an expert in pathology. And he developed today's training model, internship, residency. I remind residents, you know what they call residents? Because you used to live in the hospital. You live there. They go, Dr. Arntout, we don't live here anymore. We work from, let's see, I'm on the last hour of my shift. I'm ready to, pack it in. Hence the end of my program directorship. It's a very challenging era to educate new young trainees. But let's talk about the abuses of the past and the compensation for the future, and how do we make a finer, gentler, better system? And I think we're not there yet. That's would be my statement. But residency, you lived in residence, and then we had the clerkships, and there's also this dichotomy between basic education and clinical science. You did 2 years and you did 2 years, and they got rid of 3/4 of the medical schools. There was only 50 left, I think, 50 people left standing, and there was this better integration. And it was there that sort of began the rudimentary teaching of the physical exam technique, right? And it was there that they said, we're going to introduce the scientific method and physical exam, and we're going to teach how to do this and yada, yada. So Abraham Flexner developed the famous Flexner report. And not only did he condemn the medical schools, but he also pointed out that, people were in endless lectures and they didn't have enough clinical reading and clinical time, and they didn't participate in the exam. So there's this whole deconstruction of the old model to make the new model. Okay. And the linkage of medical schools with university, for better or for worse, is why we have the ivory tower research-based system that we have currently. And there was no tolerance for anything but allopathy. At that point, there was this is the way it was going to be. And it was the dogma then of the physical exam that began there. And we've sort of kept it the way it is. So I just introduced some concepts here. So if the physical exam were perfect, wouldn't it be great if there were pathognomonic signs that we could perform that would be so characteristic of a disease that it just makes the diagnosis unto itself, right? That would be the perfect world of physical exam. How many pathognomonic conditions exist in medicine? Well, I found one, Koplik spots and measles, but I don't think we have that around anymore. So there aren't many. Pathognomonic doesn't exist. So we're left with this deductive process of doing a whole bunch of tests with our hands and with our instruments to try to figure something out. And pathognomonic is a concept that really doesn't exist. In pediatrics, I mentioned earlier that, you can get lulled into monotony, and a lot of times physical exam is just, it isn't even done. We observe the child, and that's dating back to the early part of the century. So this construct, everyone is taught, whatever health circle you're in, that how do they relate history, physical exam, and medical diagnostic testing? Well, traditionally we say the history is 70%, the physical exam is 20%, and the diagnostic testing is 10%. And I'm just questioning, there are clearly times when history is everything and you don't need physical exam. And then there are other times where you can't get history. My father has early dementia. He's fun to talk to, but he's not a good historian, unless you're going to ask him about things in the past. And then he's funny, very fun. He's got but recent memories he can't remember. And so clearly the historian is going to play a role in how much we weigh the history in the diagnostic process. So now we're left with, okay, so where does the physical exam fit into this diagnostic paradigm? We got history. We know sometimes it's of great value, and we need to ask the right questions. And that goes beyond this 7, now 8 parameters of a symptom. That goes to, I say, mind the review of systems. The review of systems, if you don't know what question to ask because a patient has a specific symptomatic complaint and it relates to the GI system, I tell students, go to the review systems, ask all the review systems questions. You have a patient who has an orthopedic complaint or go to the review systems, because that's the safety net of questions that we need to ask that are often very relevant and telling. But back to the exam, we need to figure out, so we do the exam, but is it accurate? Right. And so the idea that we're going to elicit a finding, a sign, if a sign is present, a diagnosis becomes more accurate or more likely, such as I'm oscillating for a bruit and I hear a bruit, and therefore the diagnosis is more accurate, more likely. I mean, this is what we're doing with physical exam. And the truth be told, there is not a lot of diagnostic accuracy, not a lot at all. Because we have to face, and I'll go back to the biostatistics, but we really do have to, this is applied biostatistics with regard to the physical exam. Pretest probability, how likely is it your patient has what it is you're looking for? Okay. Sensitivity and specificity. And sensitivity, we'll just look at these so let's look at them in order here. Pretest probability. So isn't it interesting? And this is from Saunders' book, which I reference a lot. Acute abdominal pain. If that's in your differential for an adult, certainly. But the likelihood of the probability is extremely low, even in the right setting. So you hear a murmur consistent with severe aortic stenosis. or the likelihood of that diagnosis with an aortic flow murmur of severe aortic stenosis is very, very low. So we're looking at, probabilities that are low. However, you find something that has a high pretest probability, and now you're onto something. So enter the terms sensitivity and specificity. Now, a sensitive test is one when a patient has the sign, with the diagnosis, has the sign, okay? Or another way of putting it is a sensitive test is positive in disease. Or another way to put it is a sensitive test, when negative, rules out a disease, right? So if we have someone with a low pretest probability, we really want a sensitive test, because we want to be able to say, we're going to find them if they're in there. And if they're not in there, well, high sensitivity test sort of rules out that diagnosis. Now, contrast that with specificity. Specificity is the proportion of patients without a diagnosis who lack, it's kind of a double negative, who lack the physical sign. So for instance, patients without an abdominal aortic bruit who do not have a AAA. Another way, a better way to remember it is a SPIN, or negative, or NIH. Negative in health, or SPIN, specific tests when positive, rule in disease. So patient who has a high pretest probability, we want a more specific test, because we want to rule out the disease, because when in the absence of that sign, they don't have the disease. So we see how sensitivity and specificity play a role in diagnosis and physical exam. And you're going to link, again, linking these, if you have a low pretest probability, you want a highly sensitive test. If you have a high pretest probability, you want a highly specific test. So, make sense? Yeah, what's the problem with the physical exam? Well, these things suck because there's so many variables with regard to the physical exam. Let's start with the fact that how I do this may be different than you do this, and we don't have that standardization that we tried to introduce at UCONN with the videos. So let's just start with that. Then we have signs that, they're there and they're not there. That's a foreshadowing of atrial fibrillation. Okay, coming up. So it might be there, alternating irregular pulse, and then no, wait, it's not there. We're not focusing on the ball. We're not in our cognitive domain of health. We're not equanimous. Okay, and we're just not doing our job. The first talk, how we feel, how we think. It affects what we do, how we do it, how cursorily we've all put the stethoscope on the vest, shirt, brassiere, and you're not going to hear anything. Just come on, who are you kidding? Okay, we've done it, right? You just so. And then of course the sign itself is ambiguous, and we haven't subjected it to scientific scrutiny. And I'm going to argue that there's so many things that we really haven't gotten the kind of reliability or accuracy that we need. So the lack of a perfect reliability with physical diagnosis is sometimes regarded as a significant weakness, and a reason that it's less reliable and scientific than clinical imaging and laboratory testing. And hence my question, should we do away with it altogether? Which I'm not going to argue for. Okay. Now we ask the question about, all right, so we know about sensitivity, we know about specificity, we know about pretest probability. Well, what about reliability? So we've done a test, it's specific, it's sensitive, but how often do physicians examining the same patient agree that that particular sign is present or absent? Enter the kappa value, okay? The kappa statistics. Now, this is interesting. The kappa statistic is, if it's 1, there's perfect agreement. That is, everyone doing the same test on the same patient has the same result and comes to the same conclusion. That is a perfect world, which does not exist. Then you got 0, which is everyone's going to come to a random answer that's completely different and that has no basis in, there's no comparison. And so I want to introduce these numbers and then show you some of the physical exam techniques and the kappa values that when they've been studied, what they are. So if the number is 0.2, there's very slight agreement. If the number is 0.8, there's substantial agreement. And we should consider probably anything over moderate, 0.4 to 0.6, moderate agreement. This would be the equivalent of inter-observer variability, right? Not intra-observer variability, not me doing the test 3 times coming up with 3 different answers, but you or I doing the test. And how does that look? So let's look at some of the statistics. You're going to be, so by the way, there's the punchline. About 60% of physical exam findings have a kappa of greater than 6 point. That's not a lot. That is not a lot. And that's only 0.4. That's fair. So look at some of the common things that have been studied. And this is from McGee's book. Well, I'm glad we can all agree when someone's blood pressure is low. That makes me very happy. We can all agree. Okay. But finger to nose, dysmetria, the ankle jerk reflex, look at the variability on this. You'd think we could agree on that. The monofilament testing, that's pretty high. That's why this has replaced the vibratory tuning fork, peripheral pulses absent versus present. So isn't it interesting, the tremendous variability when studied in some of these techniques? Now, look on the other side, the converse, where there's absolutely, we should not be doing this stuff. Displaced trachea. Well, think about that, increased tactile fremitus. I used to think I was good at doing tactile fremitus. I would say consolidation. You have lobar consolidation. You can feel the patient breathe. I guess that's not really true. Diaphragmatic excursion, liver span. Oh, I'm really good. Watch this, guys. I can percuss in the midclavicular line, the upper and the lower limit of the liver. No, you can't. Okay. Yes. Yeah. Yes, we do. We do. It's the dogma. Yeah. You're onto something. We're going there. So then you say, okay, what about? Oh, let's abandon the physical exam. What about some tests? Some really good tests like chest X-ray or angiogram or MRI or CT. Well, when those things are studied, we can't even agree when the heart is enlarged. Okay. How about CAD? Well, if you don't specify the degree of lesion, there's all sorts of ways of interpreting occlusion, now we have maybe a calcium score, which seems to be a look, but we don't even know where to use that. But the idea is that even with these tests, a lumbar disc herniation, there's very significant variability even amongst radiologists looking at these things. So very interesting. You can't be a therapeutic nihilist when it comes to the physical exam, because there's the same kind of inter-observer variability with many diagnostic tests. Okay. And hence this gray zone that we live in. This is a great example of the limited, you say diagnostic utility. Patient comes in, a patient of ours, osteoporosis, obese. She has a history of a left total knee replacement. She injures her hip a week prior to admission. She's having difficulty ambulating. She's seen in the ED 3 days after the injury. She's discharged on NSAIDs after a hip film is negative. She returns 4 days later, really unable to walk. Now she gets an MRI in the ED, which is unusual, and it's negative for fracture dislocation or AVN. We're done, right? Well, she gets a triple phase bone scan that shows she has a stress fracture of her femoral neck. And then the radiologist goes back and goes, oh yeah, I think I see that on the MRI. We've all seen this. So the diagnostic world, the diagnostic test is no perfect panacea for replacing the physical exam. This patient could not walk. She needed further evaluation, and unfortunately in our hospital right now, that's in the ED, and she stays in the ED, and she may be there for 2 days because there's no nurses on the floors to staff the patients. My latest sin was we had a patient come in with iron deficiency, a 65-year-old iron deficiency anemia, significant weight loss. He's in a gurney, not even in a room in the ED. He's in a gurney. I tell the residents, this is colorectal cancer until proven otherwise. But Dr. Orentali, he didn't have blood in his stool. And he says he's been not eating breakfast. I go, this is colorectal cancer until proven otherwise. There's no reason for him to have ferritin of 5. And yes, he said he isn't passing melanotic stools. I go, get GI in here. Let's go. We have him scoped in the ED. He's still in the gurney. This is day 2. GI sees him. They scope him. Day 3, he's still in the gurney. He has colorectal cancer. We had to tell him in the gurney that he has colorectal cancer. I mean, because there's no room in the inn, no bed to be found in the hospital where they have enough staffing for nurses. That was our nursing shortage. This was as recent as a month ago. Horrible, horrible. Just horrible. Back to this case. The idea that, our testing is not perfect. And we've all seen this scenario. And so we're kind of left in this quagmire of what do we do, And, I would say her physical exam, her limited range of motion and her pain should have continued to lead us through the diagnostic process rather than, she doesn't have a fracture, let's get her out of here. I said I was going to take you into the U.S. Preventative Task Force. I updated this recently, so this is the old picture of it, but I did look at it recently and it hasn't changed. So, the levels of recommendation, A, B, that's good. We do it. C, probably not. D, definitely against, and I, insufficient. All right. So how many of these guidelines do we have fall into the A and B category that reflect on the physical exam? Well, a whopping, anybody? 3. Blood pressure. Okay, blood pressure. Although I should say you better have the right size blood pressure cuff. All right. We all see Omrons with the wrong cuff, and patients come in and they have, you got to have the right size cuff for the right size arm. Cervical cancer screening, if we're going to call that physical exam, it's really a diagnostic test. It's a pap smear, and then screening to detect amblyopia in children. So really remarkable how the physical exam really doesn't, and some of the things you might think have, utility: testicular exam, clinical breast exam, examination for skin cancer, atrial fibrillation screening. Although I'll swear, and I'm going to swear to it in the next talk, when you check the pulse, just think about, is it atrial fib? Because you will find it's out there. It is out there. And I say they don't screen, but in adult population, you screen. That's me talking. Okay. So, I guess I did ask the question. So now you're going to answer it. You're going to refine your answer. The physical examination I received from my physician included A, a head-to-toe exam, B, a lung and heart exam, C, excluded any part or none of the above. Okay, so we can see how we're all in agreement. It's a cursory exam. So de facto, the physical exam is not being done head to toe, complete physical exam. Even though patient wants the full meat and potatoes and the supersize, they're not getting it, right? We're not getting it. We're physicians and providers, and we're not getting it. So now I'm just going to frame it a little differently. So now I'm going to tell you, so what do we do with this? Okay. So I'm going to go to Bayes' theorem, and you're going to say, oh God, he's not going to take us into Bayes' theorem. Please don't do it. Okay. I'm not going to take you into Bayes' theorem except to say this. Bayes' theorem has to do with conditional probability. And this is Bayes' theorem applied. Okay. This guy is fishing, and the conditional probability says he's going to catch a fish if there are fish in this pond, right? Bayes' theorem says you don't go fishing in a lake where there are no fish. Okay. That is, unless you're interested in drinking beer, because you got beer on your boat and that's what you want to do. Okay. But the idea that we shouldn't be applying all these tests when there's no fish and, there's no money there. There's no Willie Sutton. There's no money there. So how do we take out and how do we compartmentalize and how do we figure out what parts of the exam? And this is where the art comes in of medicine. So I do want to say that the history of the exam came from the insurance companies. It was in 1920s that there were this really flawed study of 6,000 policyholders, said, oh, you get a full physical exam, you're gonna live a longer life, and it just turned out not to be true. The AMA, however, endorsed the idea and re-endorsed the idea until Frame, who was I think a family physician, published data saying that's not right, and the U.S. Preventative Task Force is publishing guidelines, as we know, for health maintenance. And this is what we got to go on. So you have the public and you have the providers. And the public is still expecting us to do some kind of a full physical exam, and this was a study in 2002 looking at adult respondents, and the majority said, yeah, I want a full physical because I'm not, I told my dad, this was years ago, I said, Dad, what if you didn't get a physical? What if I didn't examine you? He goes, he goes, in his New York accent, are you for real? He goes, I don't go to the doctor and not get examined. But the truth is, what do they examine? And just like we know, it's a cursory exam. So even primary care physicians, when they were asked about this, they still supported of annual physical, and it's contrary to what we know. So we're kind of left in this gray zone with what to do, and it's all fuzzy thinking. To be fair, right? There's no epic guidelines saying we must do these elements of the physical exam, although there are billing guidelines that tell us we must do 12 points of the physical exam, but they don't tell us which ones, right? And what I'm getting at is, in this study, PCPs didn't favor a selective approach, and that's what we need to do. We need to be very selective, and we need to study the exam and understand where its value is. Because the complete exam, this was from Frame's article, complete exam has outlived its usefulness and should be allowed to die a natural death. It should be replaced by a program of evidence-based, selective, longitudinal health maintenance offered to everyone. And this is probably where things need to go. Now, why don't we go there? Because there's no money in it, right? There's no pharmaceutical industry studying it. But really, this is what needs to happen. And we're not there yet. So I would frame the physical exam as a series of diagnostic tests. It's integral to the top-down kind of deductive process of medical diagnosis. And it has a place in developing the doctor-patient relationship. You don't touch your patient and you've not connected with them in a physical way. So there has to be that part of it. It's part of that personalization of care, but it has to be subjected to greater scientific scrutiny, because right now there's a lot of fuzzy thinking. And what's absolutely true is, with my residents, we sit in a conference room and they're like a bunch of IT experts. I go, we need to go to the bedside. We need to examine the patient. We need to talk to the patient, and medicine has really made its way into the classroom, and it needs to go back to the bedside. Because what we find is that our teachers don't even know how to do the physical exam, or don't do it well, and what does that mean, doing it well? So a lot of references here to go on, but I'm happy to take questions. I know I've just probably confused you, but I've stated the facts, which are the physical exam serves us. And we need to search out. The AFP recently did an article on acute knee injury and meniscal tears. They show the Thessaly exam. You do the Thessaly, you have a positive Thessaly test. That is a very high incidence of meniscal tear, meniscal damage. I mean, those kinds of signs, very specific. They're not part of the complete physical exam, but it's an example of a physical finding that, if you knew about it, it'd be very helpful to do when you're examining a patient with acute knee injury. So there are elements of the exam that are very much like that, and the signs, and I really didn't talk about that because we're talking about just an annual exam, if you will. But the concept that we do this annual exam, whether you agree with it or not, it's really not being done. And we all know that because we're the ones not doing it. So I leave you with that, and I'm happy to entertain questions.